everyone. So I will introduce Dr. Sponsellar while he's taking his mask off. He's a professor of orthopedic surgery at Johns Hopkins School of Medicine. He is another Michigan graduate. He's done so many things. I think you're a professor of urology too.
Yes.
Yes. He's done an MBA too. He basically is the Renaissance man, because on top of his university and his business acumen, he's also a lover of the arts and a great supporter of the Baltimore Symphony Orchestra. So with that said, I'm going to let Dr. Sponsellar take it from here. Thank you so much for joining us.
Thank you for organizing this wonderful symposium. And I was asked to talk about care of the whole person, the skeleton in AFM. And we'll talk about, I call it beautiful bones, long-term care of the spine and limbs in AFM. And let's see. So a little bit of orthopedic humor. We'd like to talk about contractures, hips, knees, feet, and fractures in spine. So a contracture is an inability to bend or straighten the limb. It often happens if there's a muscle imbalance from spinal cord causes. And it can also cause increased stress on an already weak muscle, making the feet difficult to stand on, impairing upright standing or upper limb use. And the treatment options include many, including just time to see if it will straighten out with strength recovery, or the use of physical therapy, stretching splints dynamically as shown in this picture, or the use of serial casts, and rarely with surgery. The hips are sometimes affected in certain levels of spinal cord injury from AFM, and dysplasia can develop because of muscle imbalance of this hip muscles during growth. This initially is painless in most kids, but it can cause pain as it evolves, as the acetabulum is deformed and the cartilage is worn from the femoral head. We try to prevent it by outward or abduction stretching of the hips, but in some cases, surgery may be necessary if the hips are very tight, if diapering or clothes changing is a problem, and this depends on tone. It can take the form of either muscle lengthening or an osteotomy. Feet are sometimes affected in muscular imbalance as well. The feet need to perform certain basic functions, such as fitting comfortably in a shoe, even if you're not a fully ambulatory person, or resting on a wheelchair, or resting on a flat surface. And abnormal pressure on certain parts of the feet can cause prominences and calluses. It may impair the ability to push off for walking. You can see certain things like equinovarus, dorsal bunions, or varus of the back of the foot, all of which cause maldistribution of pressure. The treatment for these can involve bracing, again, stretching repeatedly with casts, or finally a surgery. And this is really an individual decision because every muscle imbalance from spinal cord problems is different from every other person. Fractures often happen if the patients have decreased loading of their bones, such as lack of standing or low muscle tone, especially in younger children when the bone is naturally less dense than it is in adults. This can happen from obvious mechanisms like a fall, or more subtle mechanisms like twisting to shimmy on a pair of pants, or to twist to put a shoe on, put a brace on. And this may sometimes be less than a normal amount of force, and people may be surprised that a bone is actually fractured. But children's bones actually glue themselves together, and this glue is called callus. And if you simply immobilize them in a straight position, it will usually heal on its own, and so many times surgery is not needed. Here's an example of a femur fracture, which actually is treated in a cast, non-surgically. You can see that the bones are lined up from the second to the third image, and they gradually glue together and smooth off and remodel and grow, so that it's almost imperceptible in the long term that a fracture ever happened. Fracture prevention can be just by use. More standing is helpful to load the bones, produce better bone density. as well as knowledge of careful handling when you're dressing or transferring or bathing a patient. Vitamin D in physiologic doses or super physiologic doses can be very helpful. If there's a question, DEXA scanning, especially of the distal femurs or load-bearing parts, can be helpful to detect osteopenic and osteoporotic conditions. And there are specialists, such as at Hopkins, Dr. Jane, to manage bone density risks and prevent future fractures. The spine, I think, is the biggest source of concern in AFM patients. And we always think of our spine as something that's strong and resilient. But, we have phrases like show some backbone or show a lot of spine. But in fact, the spine is not infinitely strong. It's maintained by stabilizing forces against destabilizing forces. The stabilizing forces include the rib cage, making the thoracic spine the most stable part of the spine. Lots and lots of ligaments between the various processes and all sides of the vertebral body, and muscles. But muscles require complex coordination from the nervous system, and the level of AFM can determine possible imbalances. But there are many destabilizing forces in children. And the worst of them all actually is growth, because your spine has to grow 30 centimeters from early elementary school to high school. And that is a huge force that requires stabilization during growth. Also, gravity is a destabilizing force, and low bone density is a destabilizing factor as well. The vertebrae grow from their growth plates, 2 to each vertebral body, and the growth is fastest in adolescence. So you can sometimes develop scoliosis from unbalanced growth. And we measure the curvature by what's called the Cobb technique. You may hear the degrees referred to in various X-ray reports or doctor's reports. And I'll show you just briefly how we do that. It's simple trigonometry. First, you identify the end plates of the vertebra, then draw a perpendicular shown in the light green lines. And then the angle between the perpendiculars is the angle of the curvature, or the Cobb angle. So in this case, it will be about 35 degrees curvature, which is a mild curve. And these curves can worsen fastest in adolescence. Here's a patient showing the growth from 0 to 4, not too bad, 4 to 10, doesn't really change at all. And then the adolescent growth spurt is a fast and intense force that the muscles can't keep up with. And here you can see the curve is worsened dramatically just in these 5 years, whereas it hadn't changed much in the previous 10. So why does spine develop a deformity? Because of imbalance between the stabilizers and the destabilizers. And once it reaches about a 25 to 30 degree curve, it's much harder for the stabilizers to work. And it's kind of a tipping point for risk of worsening. The frequency of scoliosis in AFM was previously studied and reported from the Kennedy-Krieger group, looking at the initial 56 patients that had some degree of long-term follow-up in the database. And they found that almost half of them developed a scoliosis of up to 15 degrees. And the mean curve was pretty high at 30 degrees. And it developed really within 1 to 2 years in the vast majority of cases, both males and females. The risk of worsening was greater with a weakened manual muscle test and with a PAMS score more than 63. These factors were associated with high risk of developing scoliosis. Also, those who are more ventilator dependent, who had more limbs weakened by the AFM, and who had inability to independently walk or control their heads, had a much higher rate of scoliosis compared to the other group. So treatment of scoliosis involves a range of options, including seating systems, where a good seating chair, a wheelchair with head support, also supportive garments such as the DMO suit for a very mild curve, well under 25 degrees. This may provide enough support to help the kid grow straight and avoid getting to that tipping point. For the bigger curves, we use custom soft plastic orthoses called TLSOs, which are intended to guide the growth. And these are best for medium-sized curves under 45 degrees. However, they may be uncomfortable and they may cause trouble with heat transfer and with the feeling of ease of respiration. So kids can't usually wear them as much as we would like them. And in many cases, the curve will still progress, although hopefully more slowly. As curves get bigger, however, we try to guide the growth with internal mechanisms called growing rods. And these are rods that are not fusions, but just internal braces. So we anchor at the top and the bottom, and we lengthen them over time, either surgically or now we can do it magnetically in a non-invasive way to help the kid grow but still stay straight. And you can see this child actually went from age 6 to age 18 and maintained a pretty good alignment with these growing rods over time. However, in some cases, we need to perform a spine fusion, which is a permanent stabilization in the best position, usually of the whole spine in a paralytic patient. And we add biologic fusion to the rods so that the rods don't break over time in the remaining many years that they have to grow. The people who benefit most from this procedure are patients with collapsing curves who just can't hold themselves up straight with their arms or with the brace, or patients who have pain in the area of the curve, as this patient shown here. When is it best to have the fusion? As late in growth as possible. So boys, ideally 13 or above, and girls 12 or above. And by that time, the spine has less than about an inch of growth left to do. Is it ever too late to do? Not really, but it becomes more difficult to endure and the risks are greater with age. How is the operation done? It's about a 4 to 5 hour procedure in which we first make the spine more flexible to unbend the curve, and then we stabilize it with screws, wires, and rods to align and straighten the spine and add the bone graft. So the X-ray on the top turns into the X-ray at the bottom. After surgery, it's about 4 to 7 days in the hospital and 1 to 3 months out of school, because endurance and pain have to be worked through. And then often a hospital stay can be very helpful in regaining these kids the optimal amount of function. So it can take 3 to even 6 months until the person forgets that they've had surgery and feels like they're more or less normal again. The benefits of fusion are to prevent the ribs from deforming for better lung function, to eliminate the need for a brace, to improve sitting comfort in sitting time, and just to provide a more upright posture for everything else that they do in their day. Without the surgery, pain and respiratory compromise can be a problem. However, some patients can lose function after surgery in certain ways. You might not think about this, but with the spine straighter, it's actually taller, so it makes it a little harder to push up with a given length of arms. It also may be harder for those who are self-cathing to see and reach and perform the self-cath that they used to. Most of the time that can be worked through. Also to perform perineal care, because you can't twist around and reach to clean yourself as well as you did before. And also if a person gets some of their mobility by rolling around, this can be more stiff and the trunk rolls as a unit, not in a kind of a harmonious, flexible manner. So these are things that should be discussed as well with the physical therapist and the person to think through the implications of the surgery. Other complications can also occur. Neuromuscular patients are more likely to get infection as high as 5 or even 10% rate, which can require reoperation. And also there's the risk of the usual post-op things like pneumonia and pressure sores or prolonged ventilatory assistance. But in the main, these are helpful procedures for the patients. And it's important to remember that for a young child, the spine is a very dynamic structure that needs to be supported throughout growth, because growth and gravity are deforming forces, and support needs to happen early. We try to achieve a reasonable goal, but sometimes surgery may be needed in some cases. Thank you.
Thank you, Dr. Sponsellar. We'll see if the audience has questions. I am going to start with asking you about these growing rods. because we're dealing with children that have onset of scoliosis early. So what's the price these children have to pay? How many surgeries? And if you can describe a little bit
Yes.
your experience with that.
Yes, thank you. If a kid is over 10, we usually don't do the growing rods because they're close enough to maturity. But if they're under 10, like 6, 7, 8, 9, it's the procedure to do. And nowadays with the magnets, there's usually only one surgery for the growing rods, and then clinic visits can lengthen them non-surgically. And then we do the final rod at maturity. So that's basically 2 surgeries. If the kid is very, very young, like 2, 3, 4, they may need an extra surgery to change out the magnet. But the number of surgery is cut down dramatically by the presence of the magnetic technology that we've had for the past 6 years or so.
How long is that lengthening that's allowed by the growing rods?
You can get approximately 2 inches out of the growing rod, which is quite a bit. So that will usually last a 9-year-old right up to essentially near maturity.
Okay, thank you. And I have another question about this technique that I've heard about, not in neuromuscular scoliosis, but vertebral tethering, clipping on one side and the other. I know that it's used for idiopathic scoliosis, and I'm thinking that maybe it has a role, but of course.
Yes, that is a new technology. It has to be used in very young kids. It's not well proven for any neuromuscular or any syndromic condition because the forces are just so great that it tends to, not work predictably. There are some people that are trying it in some of these kids, and I would be willing to try it, for instance, in a long sweeping neuromuscular curve that's less than about 60 degrees. I think it's worth trying, but people have to understand that it hasn't been proven. It's still semi-experimental in the non-idiopathic population.
Thank you for that. And one more question. You did mention that the children's bones that break glue themselves together. How or I know we're interested about in avoiding leg length discrepancy, which is also it's mechanical because of the bone shortening, because of the fracture, but is also related to the fact that one lower limb might be more denervated than the other, thus the growth is going to be impaired. So do you have any tips, any good points on how to follow up, when to get worried, how to address it, when to send it to the orthopedic surgeon for more aggressive intervention?
Yes, that brings up a good point. And you might not believe this, but a broken bone in a juvenile will actually compensatorily overgrow by about 1 centimeter over the year after fracture. So you can accept up to 1 centimeter or 1.5 centimeters of shortening and overlap and expect it to self-remedy. If the discrepancy is more than that, or the kid is older, then you might need to think about converting to surgery if limb length inequality could limit their function.
Okay, thank you. Dr. Pardo, do you see any other questions?
No, there are no other questions, but I like to thank you, Dr. Sponsellar, for being available. I know that you are very busy, but we really appreciate all the information and education that you are providing to the acute flaccid myelitis community. And it is great to have you here. Thank you so much.
Thank you for all that you've been doing, and I really appreciate the chance to be involved. Thank you.
Thank you so much.
I'll stop.
You know.